So this is the Pitt Season 2, Episode 5. Happy to have you back. Did the last 2 episodes without you, so you were sorely missed.
It's always fun to do these together.
Okay, so let's jump in. Pitt Season 2, Episode 5. Here we go.
Home hospice patient with a history of lung cancer. New onset tonic-clonic seizure with right lower leg pain.
Victim of assault with diffuse blunt trauma. He's got bruising to the face, the right chest, 10-centimeter laceration to the left arm. BP's 136/84, pulse 102, good sats, 95 on room air.
So yeah, 2 interesting and potentially sick patients coming in at the same time. One is a seizure, and they say that she's a hospice patient. It sounds like she has end-stage cancer and is on home hospice and then had this seizure. So, I mean, seizures, like, broadly speaking, there's many different causes, but can be really scary if somebody has a first-time seizure, especially at home. And then simultaneously, we got this other patient coming from prison, which is also something that we see really commonly in the ER. And it sounds like he was assaulted. So, and then they also have the cellulitis patient that they're concerned about sepsis that Dr. Robbie's going to check on at the same time. So a lot going on.
Yeah, a lot going on. The first thought that goes in my mind in that lung cancer patient, of course, is whether this cancer has metastasized.
Exactly. Yeah.
Cancer starts in one place, but it can spread to other places. And if she's having a new sign of an issue, it sounds like in her brain, a common cause of that in somebody who has end-stage lung cancer would be that cancer has spread. So we'll see, but that's kind of my pre-rounds diagnosis on that one.
For sure. Yeah. And she'll get a CAT scan of her head to see if there's any new metastasis, if there's any bleeding. Some kind of brain imaging is paramount in any kind of first-time seizure, especially somebody with a cancer history. Patients who have known seizure history won't always get a CT scan in the ER. Very often there's not a need for it, but in a first-time seizure, for sure.
Can we get the cuffs off once he settles?
Not a chance. Orange jumpsuit, he's cuffed for a reason.
Let's go.
I thought that exchange was kind of weird. The correctional officer is like, oh, I can't take the cuffs off. Usually the correctional officers are pretty accommodating. The patient's care comes first. So if we need to take, the handcuffs off or something to examine the patient, they're usually pretty accommodating about that.
Yeah, in my experience as well. It is a tension point, though. I think that comes up in a lot of emergency rooms across the country. The tension of the treating team and the police, and having the police kind of right by you at the bedside the entire time is always... I appreciate them highlighting that there are these exchanges, and it is kind of a strange thing to have to ask and say, can you uncuff them for us to do the thing? It's a different type of relationship that you have kind of treating there in the ED. But I agree with you. I think, taking care of the patient does come first then. Without a clear reason in that case, just saying that he's in an orange jumpsuit doesn't quite feel right. It's not as if saying because he is, currently in jail, that means he is unsafe to be uncuffed in this one moment, right? It's not quite what I've seen.
Everyone on my count. 1, 2.
Hold on. Go.
1, 2, 3.
I just think it's so funny, like, how this is written, because that's often what will actually happen. Like, the guy might be handcuffed to the stretcher. That's what they will do sometimes for patients who are incarcerated. They'll, actually handcuff them to the stretcher. It's just funny to me that these little moments that, seem very familiar. Oh, you got to unhandcuff the guy from the stretcher before we move him. That's portrayed here.
Yeah, it really shows the nuances of the writing here to be able to highlight the little moments that make this very real, and in some ways mundane and just catch this little thing, but you're totally right. I'm with you.
The airway's patent.
Good lung sliding on the left.
Sorry.
Good on the right too.
How are the lungs?
Good breath sounds. No crepitus.
So we're doing primary survey. We've seen this now, we see it dozens of times in the emergency department. So they're going through the ABCs. We've talked about advanced trauma, life support, ATLS. So they're going through airway, breathing, circulation. They're going to do this FAST exam, the focused assessment, sonography, and trauma, to look for internal bleeding and to look for a collapsed lung. That's what we're doing with the ultrasound here. So again, it's just trauma is very protocolized, just going through the steps.
Absolutely. And this is one of the actually useful cases for a stethoscope.
Yeah.
Because There's not that many times where it actually tells us something useful immediately. It's something very useful, and checking for breath sounds on both sides to make sure both lungs are inflated, quite important and quite useful.
Yes, exactly. We check with the stethoscope, and then we can double check with the ultrasound. The ultrasound can actually see the lung, and I think she calls out good lung sliding, so we can see the motion of the lung in the pleura, which is the lining around the lung, and it appears like it's sliding on the ultrasound when there's no collapsed lung, so no pneumothorax.
Gus, bite down hard on this for me. Sorry, Gus. Positive test.
Yeah, so we have the patients bite down in a tongue blade. If they have a mandible fracture or a jaw fracture, then they're not able to do that, to maintain that kind of closed jaw against the tongue blade or the tongue depressor.
Cycling the BP.
Okay, this redness is now a centimeter over that line, and this might be a bulla forming.
So I love this case. So this is a patient, again, who came in initially with cellulitis in her leg. An infection of the soft tissue of the leg, was put on oral antibiotics, didn't work. She came back, it got worse. So if you see that blue line around the area that's red, they drew a line where the cellulitis extended to see if it was extending past it. And even when this patient first showed up in a previous episode, I was already suspicious that something was going to go wrong here, because not common, but one of the scary complications of an infection like this is what's called necrotizing fasciitis, or neck fash, which is a much more serious infection, what's colloquially referred to as like flesh-eating bacteria. And so that's sort of what we're already starting to worry about, is hopefully in the back of everybody's mind here. That redness is spreading past the line. That doesn't by itself mean neck fash, but it does mean that the infection is getting worse. And then he says that there's a bulla that's forming. So a bulla is like a bubble on the skin, and it suggests that there's gas-forming organisms, which is a much more serious, again, type of quote-unquote flesh-eating bacteria that causes this necrotizing infection.
Yeah, and to be clear, most cellulitis does not turn into necrotizing.
That is correct, yes.
Most cellulitis gets treated and goes away, and you never come back to the emergency room. But
That's
your
right.
mind was thinking, like, how do we up the stakes on this cellulitis? And
Yes.
this is the drama of the cellulitis. I also love the, it's important to point out that we drew that on her leg, like that blue line there. And it is one of those like kind of comical things that we do in a way, like in the emergency department. I do this in primary care as well, because it's so useful just to have this visual that you're looking at now. Because if somebody is being treated, they're on the right antibiotics, we're covering the right organisms, like it should not spread. It should pretty quickly start receding. And when you've treated a cellulitis successfully, people start to feel better generally relatively quickly, and it starts to get better. It's a very, very, very helpful indicator to be able to see that across this line. You can imagine, even if we had taken a picture of her leg before and after, it'd be really hard to tell.
Right.
And so the line it's a really, really useful tool.
Absolutely. And also, to be clear, they didn't do anything wrong at the beginning. It's reasonable. They put her on the oral antibiotics. They sent her home. It's not like this was missed. It's just that sometimes there is this, as you said, you correctly point out, a rare complication of cellulitis where this gets worse. It doesn't get better with the oral antibiotics, and then we end up in this type of position. I want to take a quick break here and tell you about Appendix. As an ER doctor, I don't have all the knowledge that every specialist has. So when I see a patient and I have a question, I rely on my specialist colleagues to help figure out the best plan of action for a particular patient. But what's weird is the patient never sees that conversation. It happens behind closed doors, and all of that context, that whole discussion, just gets lost. As a concierge primary care practice, Appendix gives you a private doctor that's looking out for you, who you can text and call and email anytime. And this is a way more in-depth level of service than you've ever seen from a doctor. And instead of a typical annual physical that only catches problems that have already happened, Appendix uses the latest tools like cutting-edge labs and imaging and wearables to prevent problems before they happen. And they focused on the things that we know actually matter, but what most doctors ignore, like helping you eat better and sleep better and ultimately live longer. And your doctor at Appendix does this not by themselves, but in partnership with a team of specialists. This team of specialists meets and debates your care, just like has always happened at academic medical centers, except in this case, it's recorded, and you actually get to see the conversations that take place, kind of like a podcast about your health. If you actually want to get serious about taking better care of your health, It helps to have a primary care doctor who's in your corner and gets what you're trying to do. And it helps to have someone who can approach things in a modern way that can actually make a difference in your life. That doctor and that team exists. Check them out at appendix.com.
When was she diagnosed?
7 years ago. Resected a lobe. 4 cycles of platinum chemo gave us a couple good years, but then it spread to the bones.
Has she had radiation therapy?
It shrunk down the mets, but they're still there.
That's why you're at hospice at home.
I think there's something to call out there on the hospice side, which is that, like, it's an interesting thing to have a hospice patient in the emergency department.
Yeah.
Period. When you have somebody who's on home hospice, and when somebody's in hospice, that means that they've been essentially they have a diagnosis that means that they have less than 6 months left to live. We think, right? To the best of our ability. Sometimes we're wrong on that. Sometimes it's shorter, sometimes it's much longer. And it means that we've switched the intentions of the care to be more about keeping that patient comfortable rather than trying to extend their life for the most part. That said, it doesn't mean that when patients have complications of disease that we can't treat them in the hospital. I think that's a common misconception for folks, that if you're on hospice and something happens, you can't go to the hospital to get treatment for it. A seizure is a great example of something that by treating the seizure, we give this patient quality of life back, right? And by putting her on a benign seizure medication that can prevent future seizures, she can continue to kind of live out her days, and it makes sense to do this. It mostly just means they're probably not giving her chemotherapy anymore. There are still some cases where we might give what's called palliative chemotherapy, so chemotherapy that's meant to reduce the cancer burden to help you feel better. But most cases, we're not giving chemotherapy for this patient.
We can knock 40% off your final bill.
That's great. Mm-hmm.
I stay here for a few days. My bill could be over 100,000, right?
Not necessarily. Couldn't we just admit him to med-surg instead of ICU? Wouldn't that be a lot cheaper?
First of all, it's just awful that this patient's critically ill, and then we're having this conversation. The hospital's like, we can give you 40% off. Oh, yippee. Like, it's just, just that we're in that place. And then there's this second layer of like, who is this being written for? Because they're right that maybe this patient's DKA could be managed differently, and they go on to talk about giving him subcutaneous insulin instead of an insulin drip. Typically, an insulin drip has to be managed in the intensive care unit, which is more expensive. Possibly, if he got subcutaneous insulin, that could go to the regular hospital floor, which would be less expensive. But it's like the writers are like talking both to us as the doctors who might be making these decisions or help patients make these decisions, and also to patients who might find themselves in these situations and have to advocate for themselves. And it's like the clinical piece and the financial piece. And I just found the whole thing kind of super interesting the way it was set up.
Yeah, I think that, they highlight the black box dynamic of pricing at the hospital, which is
right.
They have this hospital administrator seemingly who at the beginning of the scene seems like she's really trying to be transparent and helpful, but you realize that it's all nonsense. It's, we take a big discount off, but it could be hundreds of thousands of dollars. It doesn't take a very smart person to understand that if this person doesn't have insurance and or is having trouble paying, that statement you just said actually is meaningless. It's just like a maneuver to get through the moment and be like, you'll fight this after you leave the hospital when we send you a big bill. And so that you don't get mad at me in this exact moment. It's actually nonsense, right? And she's not actually, he does the math himself. And she's not doing the math to say, well, this could still end up being more expensive than, how much ever you were thinking. And I think that's just a really good example of how much we really screw patients when it comes to pricing in the hospital. Like, it is a black box, it is confusing, nobody knows how much you're gonna get charged, and there's a lot of this kind of hedging around it, in part because hospitals are complicated organizations and it's hard to know exactly what a course will look like. But I think this is a very painful thing to have that experience. So I'm with you on that. In the other way they're talking to us, I think the insulin drip is an interesting one, because many of us who have admitted patients to the ICU, we do know that the insulin drip is an indication to be in the ICU, but it's probably one of the weaker indications compared to how sick people typically are in the ICU. It's usually about how frequently you can get labs checked, and that's why they have to go to the ICU to be able to keep an eye on certain labs, but not because they have a breathing tube in or they're, acutely ill in that same way we think about patients who typically are in the intensive care unit. So this is kind of a nuanced thing that they're like, well, we might be able to swing this one. Like when I was at UCSF, for example, because our general floor had so many sick patients on it, sometimes you could swing something like an insulin drip because the nursing was more trained and they had the ability to do this. But anyways, I just thought that was kind of a deep cut and kind of the perfect one to be able to set this up in this way.
It just raises this question of, should we make treatment decisions based on the cost of care? And it's not something that we usually do. It's like, if the insulin drip, that's what we were taught, DKA needs an insulin drip. That's kind of the most typical treatment. And we don't usually stop to say, is there a less expensive way that we could treat this? Maybe it's something that we should stop to ask more often.
I think it's the fundamental question. And I think there's a lot of doctors who would say, that's not my job to think about cost. And it's my job to just tell you what the best route is from a treatment perspective. But I think this highlights, especially if you're in a position where you are treating patients who have financial insecurity or limited financial resources, that it's such an important part of being able to deliver good care to people, because having this person be discharged with a bill that's going to bankrupt them and, really set them back. And if we really are saying that we want to provide the best care for our patients generally, and not just for the 2 days while we're looking at them, we have to think about the downstream consequences of our decisions, right? This comes up in the primary care setting all the time around medications, right? Some medications have higher copays, some medications are covered or not covered. And we are often in this conversation of doing some math with patients on what makes sense, right? And sometimes a new medication might be very expensive, but an old generic that's about the same efficacy might be a lot cheaper, and hard for a patient to know that. But, then whose job is it? And sometimes I think it is ours, but it's a complicated one.
I thought it was just a little swelling because I'm on my feet all day.
EP's down to 85 over 40.
How much LR is it?
Full bolus.
Another liter, and let's start levo-fed titrate to a map of 65.
Can someone please tell me what's going on?
So everybody should be really worried at this point. So her leg is showing these bullae, which means that there's a gas-forming infection. And now her blood pressure is dropped to the 80s systolic. So we talked briefly in a previous episode. Everybody always worries about high blood pressure. In the emergency department, we tend not to get too worried about 1 or 2 high blood pressure readings, but 1 low blood pressure reading is actually a very bad sign. And it suggests that this person is in shock. And with the presence of an infection, it suggests that she's in septic shock. So this is kind of the worst case where this infection has now become overwhelming and her blood pressure dropping, her organs are potentially shutting down. And with that type of infection that she has in her leg, she very well may need surgery on her leg, and in fact might lose her leg because of the severity of that infection.
Yeah, I think that's important to call out on this one, and maybe to take a step back on kind of the series of events here. She has an infection to start. That's a local infection. And we have examples of these all across the body, right? You could have a UTI in your bladder, a cellulitis on your skin, a pneumonia in your lungs. If that infection stays in that place and we treat it, generally people get better. They're not that sick. They often don't have to stay in the ER for very long. If that infection starts to spread and starts to essentially get into the bloodstream and cause a response across the entire body, that's when we get into this territory that we are here called sepsis. And then when the blood pressure drops because of that, we worry that we are now going to be in septic shock. And that is kind of the, like you said, one of the later stage, more serious manifestations here, that her whole body and her heart essentially are now being affected by this infection. And even in this case, like you said, if this was, we do see septic shock also frequently. And there are different levels of concern depending on where the infection is at. This particular schema here of septic shock with concern for necrotizing fasciitis, this is a bad prognosis for this patient, in part because we now have a very high suspicion also that we're not going to be able to treat this infection with antibiotics alone. Right? Because this infection has grown to her leg. If she had asked me that question, do I need surgery? He said it's a last resort. I would have said probably, but we'll try our best to avoid it in here. Because like that bulle and the way she's presenting looks like, you know, she's kind of heading towards a procedural intervention pretty soon.
Right. Necrotizing fasciitis, part of the reason that it's so serious is because it's a surgical disease. It's a type of infection that needs surgery to fix. Antibiotics alone are not going to fix it.
Right.
Am I going to be okay?
We're doing everything that we can to make sure that you are. Jesse?
Be ready to intubate if you need to. You want me to call Langdon?
No, I will be right back, and you can call surgery and tell them to get their heads out of their asses and get down here.
Yeah, so they're talking about intubating her. Her oxygen has dropped. Her blood pressure is not high enough to perfuse her vital organs, which is probably the cause of her hypoxia here. There's also some secondary issues that can arise in the lungs, like just from the presence of septic shock. So that might be another issue. So they're talking about potentially intubating her. And he says, tell surgery to get down here, because this is now a surgical problem. This patient needs to go to the operating room, most likely. And there's kind of a tension between the emergency department and the surgical team. He's really worried about the patient. Surgery hasn't seen the patient yet. Maybe they don't realize, you know, how urgent it is. So he's like, tell surgery to get down here, you know, and try to expedite things.
Yeah, 100%. This is one of those very tricky dynamics where you're really dependent. You know, he can do only so much without the help of a surgeon in this situation, which he is pretty quickly recognizing. Would you walk out of that room?
It depends, I suppose, what her pulse ox was after they put her on the non-rebreather. If her oxygen came back up and she's mentating okay, which it looks like she was when we left, like her mental status was reasonable, she was awake and talking.
Right.
And she had only gotten, I didn't hear exactly what they said, but she got LR, which is lactated ringers IV fluid. It's a type of IV fluid. I didn't hear how much she got, but we want to give this patient IV fluid to try to bring their blood pressure up. So there's still some time to resuscitate her. Like they can give her more fluid, they can give her some oxygen, and we really like need surgery to come down and hopefully take the patient to the operating room. What happens from the time, like from this moment until the patient goes to the OR, unclear how much more needs to be done. It depends on like the next few minutes, what unfolds with the patient.
Right. And I think he also told, is that a nurse in that role?
I think so, yeah.
Started a medication called Levophed, which is a blood pressure medication that keeps your blood pressure up. So that they'll give her fluids, they'll put her on this medication. Most of the time with septic shock, between the two of those, we can stabilize the blood pressure relatively quickly. So we'll see.
They have a direct laryngoscope. They have this, Dr. Abbey has this light in his hand, essentially, and he's looking at the vocal cords with this laryngoscope and putting the breathing tube in. When we've seen this previously, it's been on video. Instead of a light in his hand, he has like this video camera device essentially in his hand. But this is like the old school way to do it.
You seen neck fash before?
In a textbook. I was a med student 2 weeks ago. Gotta show this to Dr. Garcia.
Okay, Jesus Christ. Go get anybody else from your service down here. Shamsi, Miller, Walsh.
I don't know any of those people.
Don't take this personally. I just need a fucking grown-up down here.
And that's really harsh.
It's tough.
So an intern comes down. Remember, it's July, so the new interns start in July. He says, I was a med student 2 weeks ago. So this is like a brand new surgical intern who maybe doesn't understand the gravity or the urgency of this situation. And I guess what Dr. Robbie's kind of driving at here is like, once this diagnosis of neck fash is made, like this patient really has to urgently go to the operating room. Like the more time that elapses until they get to the OR, it could cost them their life. So it's not the like typical, we send down the intern, they take a look, and then they go back and talk to the attending, and then in a couple hours, the attending comes down, and I think Dr. Ivy's trying to drive home here is like, this all has to happen right now.
Yeah, we've talked a lot about like the different ways of balancing medical education in the hospital setting. And one of the ways is to know when you have to throw med ed out the window. And say like, this isn't for your learning because this is too much of an emergency. I need you to run and go get somebody who can make a decision faster. Because he also knows, because now he's done this a million times, that the only person who can make a decision to take somebody back to the operating room is either an attending or sometimes a chief resident can make that decision on the spot.
Yeah.
And so he's like, okay, no matter how serious even this intern takes it, this decision can't be made on the sooner side, right? And so I think there is a logical thing that he's thinking in his head to kind of override this moment and just say, don't take this personally. And honestly, most people don't say, don't take this personally. So that was, it was quite harsh, but at least he said that, which, I give him a little bit of credit for. But yeah, it's, you got to know when to push the override button on the system and the hierarchy and the way things that are done to be able to take care of patients. So I respect that. And I think that's also a very real experience.
All right, by the time you get your CT, it's going to be up to her waist. She's going to need a hemicorporectomy.
She needs a CT scan.
How about stainless steel scan?
For Christ's sake, Rabinovich. Robbie, what the fuck are you doing?
So surgery comes down and she asks for a CT scan of the leg. Now, CT scan would confirm gas-forming organism. On the CT scan, you'd see gas. You'd see like bubbles of air in the tissue. And that confirms the diagnosis of necrotizing fasciitis, of neck fash. But you don't need that CT scan. It's what we call a clinical diagnosis. If you look at the patient and you have a high enough suspicion for neck fash, that patient should go to the operating room. So that's what they're kind of sparring over here.
Right, and he basically pulls a move to force the hand, right? Because basically he says, well, I'll just show you what's inside this leg, because then as soon as you see that, the decision will be made for you. But yeah, there's a whole thing we can chat about here around things that were, this is a great example. It is a clinical diagnosis. You don't need the CT scan. But as CT scans have gotten easier and easier to get, more and more, there have been moments where it does make sense to get a CT scan in a case where 20 years ago, maybe we would have taken somebody to the operating room. In this case, septic shock, she's intubated, right? It's you've got to kind of listen to those clues to the best you can.
Thank you so much for joining us. If you enjoyed the video, make sure to like and subscribe, and we will see you next time.